Today we're tackling, well, a genuine medical mystery. It's a case so incredibly rare and presenting in such a unique way that it's seriously tested diagnostic skills and surgical thinking. We're going to unpack how a surgery from years ago could set the stage for a really perplexing problem much later on.
Yeah, and what makes this, particularly fascinating is the condition itself, Bouveret syndrome. It's already vanishingly rare. I mean, it accounts for maybe 1 to 3% of gallstone ileus cases. And gallstone ileus itself is uncommon, less than 4% of all bowel obstruction. So we're talking rare upon rare.
Okay.
But the case we're looking at today, it adds another layer entirely. It's actually the first reported case in English of Bouveret syndrome happening in someone who'd previously had a subtotal cholecystectomy.
A subtotal one, so not the whole gallbladder removed.
Exactly. Part of it was left behind. And this case really shines a light on the potential long-term, sometimes really unexpected consequences of that remnant tissue.
That's a huge distinction. It explains why this specific case report got so much attention.
And I should add, our discussion is also really guided by a thorough review of this case by Dr. Reza Lankarani. He's a general surgeon, the founder of the Surgical Pioneering newsletter and podcast series, and he's on the editorial board for the Genesis Journal of Surgery and Medicine. His insights were very helpful in framing this.
Absolutely. Dr. Lankarani's perspective adds real depth here. So it's just a remarkable example, isn't it? How even surgeries that seem, relatively standard can have these complex, delayed effects that demand real clinical sharpness.
That's the perfect way to put it, sharpness and vigilance.
Right, let's start with the basics. What exactly is Bouveret syndrome? Can you break that down?
Sure. So at its core, Bouveret syndrome is a specific and rare cause of gastric outlet obstruction. That means something's blocking food from leaving the stomach.
Yeah.
What makes it Bouveret syndrome is how it happens. You have a large gallstone, right? Instead of staying put, it actually erodes, it bores through the gallbladder wall.
It makes its own way out.
Essentially, yes. It creates an abnormal tunnel, what we call a cholecystoduodenal fistula, directly connecting the gallbladder to the duodenum, which is the very first part of the small intestine. The large stone then travels through this self-made tunnel and gets stuck, lodged right there in the upper duodenum, or the pylorus at the stomach exit, causing the blockage.
Wow, so it's not just a simple blockage, it's a gallstone that has literally tunneled its way to cause trouble. And I think you mentioned despite being so rare, it's actually been known for quite some time.
It has, yeah. Descriptions go back surprisingly far, even to 1770. But it was the French surgeon, Léon Bouveret, back in 1896, who published 2 really clear case reports. And that's why the syndrome carries his name. But even with over a century of medical literature, it's still incredibly uncommon. Like we said, gallstone ileus, any gallstone causing bowel obstruction is rare, less than 4%, and Bouveret is just 1–3% of those cases. It's a true medical zebra.
A zebra indeed. Okay, foundation laid. Let's pivot to the patient in this specific report, the one that makes this rare condition even more unique. Tell us about her presentation.
Right, so this is a 54-year-old Caucasian woman. She presented back in 2024 at James Cook University Hospital. Her symptoms had been building for about 3 weeks. Things like increasing burping, then progressive vomiting for solids, then liquids too. Reduced bowel movements, noticeable abdominal swelling.
Sounds like a pretty clear obstruction picture building up.
It does. And clinically, they noted mild tachycardia, a slightly fast heart rate, and her upper abdomen, the epigastric area, was distended when they examined her, all pointing towards a blockage high up in the GI tract.
Okay, and what was that crucial detail in her past medical history, the piece that really set this case apart?
That was her surgical history. 6 years earlier, back in June 2018, she'd undergone a subtotal cholecystectomy. This means only point of gallbladder was removed. It's sometimes done when inflammation is really bad or the anatomy is tricky, making a full removal too risky. So surgeons intentionally leave a part behind.
And the Bouveret syndrome developed from that leftover part.
Precisely. Developing Bouveret syndrome from remnant gallbladder tissue after that specific type of partial removal, that's what hadn't been reported before in English. It really underscores the need for long-term thinking sometimes.
That is a fascinating twist. Okay, so she has these persistent, though maybe non-specific symptoms, plus this unique surgical history. How did the clinical team actually zero in on something so incredibly rare? What was the diagnostic path?
Well, the big clue came from imaging, specifically a CT scan. The CT showed exactly what you'd expect with an obstruction. The stomach and the first part of the duodenum were significantly dilated, blown up essentially. But the critical finding, the smoking gun, was seeing a large gallstone clearly visible within the remnant gallbladder tissue. And this remnant, with the stone inside, was pressing on the duodenum from the outside extrinsic compression. They also saw a narrowing, a stricture, in the duodenum itself.
Okay, so the CT really pointed the finger directly at the remnant gallbladder and the stone.
It really did. That combination of findings on the CT immediately put Bouveret syndrome, linked to the prior surgery, high on the list of possibilities.
So with that strong lead from the CT, what came next? Did they use endoscopy to confirm?
Yes, exactly. They performed an OGD, that's an esophagogastroduodenoscopy, basically, a camera down the throat into the stomach and duodenum. And the OGD confirmed a blockage right at the junction of the first and second parts of the duodenum, the D1, D2 level. They couldn't see past it. Plus, there was a lot of undigested food stuck in the stomach, further evidence of the holdup.
Could they do anything during the OGD?
They did try. They performed a balloon dilatation, trying to stretch the narrowed area. That allowed them to advance the scope a bit further into D2. And importantly, they were able to place a feeding tube, an NJ tube nasojunal, past the blockage to provide nutrition.
So putting it all together, the CT showing the stone in the remnant, compressing the duodenum, and the OGD confirming the blockage, visually the diagnosis was solidified.
Exactly. Bouveret syndrome, arising as a late complication from her subtotal cholecystectomy 6 years prior. All the pieces fit.
Once the diagnosis was clear, what was the initial plan? Did they jump straight to surgery or try other things first?
They started conservatively. Standard approach initially. Put down an NG tube, a nasogastric tube, to decompress the stomach, relieve that distension, gave her 5E fluids, and as we mentioned, they used that NJ tube placed during the OGD for nutritional support. The hope was maybe things would settle, stabilizer.
But I'm guessing, given the mechanical nature of a big stone causing blockage and compression, conservative measures probably weren't enough.
You guessed right. It wasn't a long-term fix. She kept having symptoms. And a major issue arose. The NJ tube kept getting dislodged. They tried multiple times to replace it, even using fluoroscopy like live X-ray guidance, but they couldn't get it back in the right place.
Ah, so her nutritional support was compromised.
Right. That, combined with the ongoing blockage symptoms, meant conservative management had failed. It wasn't sustainable. So that led to the decision to refer her to a specialized tertiary hepatobiliary unit, a center equipped for complex liver, gallbladder, and bile duct problems for definitive surgery.
Okay, and this brings us to the surgical solution, which sounds like it was quite comprehensive. They went for a one-stage operation.
They did. A single major operation designed to address everything at once. They performed an elective laparotomy, an open abdominal surgery, and during that operation, they did several key things. First, a completion cholecystectomy, removing the rest of that gallbladder remnant.
Getting rid of the source of the problem.
Precisely. Then, they tackled the fistula, that abnormal tunnel. They carefully closed the cholecystoduodenal fistula. They reinforced the closure using a patch made from the falciform ligament, which is a bit of tissue connected to the liver.
Providing extra strength to the repair.
Exactly. And finally, because the duodenum itself was narrowed and potentially damaged, they performed a gastrojejunectomy. This is essentially a gastric bypass procedure, creating a new connection from the stomach directly to a lower part of the small intestine, the jejunum, effectively rerouting food around the obstructed area.
Wow, that's completion cholecystectomy, fistula closure, and a bypass. That's a lot in one go. Why
Yeah.
choose such a big single operation? Why not break it up?
That's a really important point, and the report addresses it directly. They opted for this one-stage approach because, and I quote, the patient was relatively young and did not have other comorbidity. So while it's definitely more complex technically and carries a higher immediate risk than just, say, removing the stone initially,
Right.
for her, being relatively fit, it offered the best chance of a complete definitive cure in one shot. Tackling the remnant gallbladder, the fistula, the obstruction, all addressed. And doing it in a high-volume, specialized center meant they had the expertise for this kind of complex procedure.
Okay, that makes sense in her context. What is the alternative then, the staged approach you alluded to, especially for someone perhaps older or less healthy?
The alternative is usually a two-stage strategy. Stage one is focused on just relieving the immediate emergency, the obstruction. That typically involves an enteral lithotomy, which is just a surgical incision into the bowel to remove the obstructing stone. Get the patient out of immediate danger, let them recover.
Stabilize first.
Exactly. Then, weeks or sometimes months later, after the patient is stronger and inflammation is settled, they go back for a second operation. That second surgery would address the underlying issues,
Yeah.
repairing the fistula, removing the gallbladder or remnant if needed. The advantage is it breaks down the risk, especially for frail patients. The disadvantage, sometimes patients don't or can't come back for that second stage, leaving them at risk for problems recurring.
Got it. So different strategies for different patient situations. But for this particular patient, the one-stage approach paid off. How did she do afterwards?
Remarkably well, actually. Her post-operative recovery was described as uneventful. No major complications. She was able to start eating normally again, gradually, and was discharged home just 6 days after this major surgery.
That's a great outcome.
It really is.
Yeah.
And importantly, at her follow-up appointment 2 months later, she was completely symptom-free. No more vomiting, no distension, and she was actually gaining weight, which is a fantastic sign that the obstruction was fully resolved and her digestion was back on track.
That's fantastic news. Such a complex problem with a successful resolution. So, stepping back, what are the broader lessons here? What does this case teach us about diagnosing and managing Bouveret syndrome more generally?
Well, it strongly reinforces that Bouveret syndrome is, a real diagnostic puzzle. And a therapeutic challenge, too. The symptoms, nausea, vomiting, pain, swelling, they're so nonspecific. They could be caused by dozens of other much more common GI problems.
Right, easy to misdiagnose or overlook.
Very easy. And the obstruction isn't always constant. It can be intermittent, meaning symptoms come and go, which can delay diagnosis even further. Even that classic Wriggler's triad, the doctors learned about seeing air in the bile ducts, pneumobilia, signs of small bowel obstruction, and the gallstone itself, and an abnormal location on X-ray that's only actually seen in maybe 20 to 50% of cases. So you can't hang your hat on finding that triad.
So if the symptoms are tricky and the classic signs aren't always there, what tools are most reliable for clinicians trying to figure this out?
The CT scan really is the MVP here. It's considered the gold standard for diagnosing gallstone Lewis in general. Studies show it's got excellent accuracy, around 93% sensitivity for detecting the ectopic stone and any complications, and practically 100% specificity, meaning if it sees it, it's almost certainly there.
Okay, CT is key. What about other imaging? Ultrasound, MRCP.
Ultrasound is useful because it's non-invasive and readily available, but its view can be obscured by bowel gas, which is common in obstructions, so sensitivity is a bit lower, maybe 60 to 88%. MRCP, that's magnetic resonance cholangiopancreatography, is excellent for getting detailed pictures of the bile ducts and critically identifying fistulas. Very high sensitivity and specificity there, over 90%, but it's less sensitive for seeing the actual bowel obstruction itself. So CT is usually the first go-to for the overall picture, but ultrasound and MRCP can provide important complementary details, especially about the biliary tree and fistula.
Makes sense. Now, before resorting to major surgery like in this case, are there less invasive ways to get the stone out? Endoscopic options.
Yes, absolutely. If possible, attempting endoscopic removal is often the first line. There are several techniques. You can try mechanical lithotripsy using instruments through the scope to physically crush the stone, or electrohydraulic or laser lithotripsy to break it up with energy pulses. Sometimes extracorporeal shockwave lithotripsy, ESWL, using shockwaves from outside the body can be tried. Other endoscopic methods include using balloons to pull the stone out, or specialized baskets or snares to grab it, or even just trying to gently push the stone further down to a wider part of the intestine.
So quite a few endoscopic tricks up their sleeve.
Definitely. But success really depends on the stone's size, its exact location, how impacted it is, and critically, the expertise and equipment available at that center. If those endoscopic methods fail, or if the stone is just too large, or if the patient is too unstable, then surgery becomes the necessary next step.
Understood. And just briefly, are there known risk factors that make someone more likely to develop Bouveret syndrome in the first place?
Yes, the generally recognized risk factors are things like advanced age, being female, having a known history of gallstone disease, obviously, and specifically having large gallstones typically defined as bigger than 2.5 centimeters, or about an inch in diameter. Those big ones are more likely to erode through the gallbladder wall over time.
Right. Bigger stone, more potential for trouble.
But really, the core message from this specific case report, the one we've been discussing, particularly for doctors listening, it's the absolute need to keep Bouveret syndrome on the radar as a potential, yes rare, but real long-term complication after a subtotal cholecystectomy. You can't just assume that partial removal solves all future gallstone issues.
Don't close the book on it.
Exactly.
Yeah.
Early diagnosis, which often requires just having that high index of suspicion in the right clinical context, coupled with a multidisciplinary team, gastroenterologists, radiologists, surgeons working together, that's crucial for managing this unique group of patients effectively. It's a strong reminder about vigilance, even years down the line.
This has been, well, a truly fascinating deep dive. It really highlights the incredible complexity of the human body, doesn't it? And the constant need for that medical vigilance you mentioned. This single case, the first of its kind reported in English, following a subtotal cholecystectomy, it just perfectly illustrates the diagnostic and therapeutic hurdles that can pop up sometimes years after an initial procedure seems successful.
And it really makes you think, doesn't it? It raises this important question. How do we keep refining our diagnostic strategies to catch these zebra cases, the really rare conditions,
Yeah.
especially when they present maybe years later looking like something else entirely? It's just, I think, a powerful testament to the fact that even surgeries we consider fairly routine can have these incredibly long, complex potential after effects. It demands constant learning and adaptation from clinicians.
So what does this all mean for you listening?
It's really a stark reminder, I think, that sometimes the seemingly smallest details in a patient's history, like the type of gallbladder surgery they had years ago, can hold the absolute key to solving the most challenging medical puzzles. It just underscores how medical knowledge is always evolving and the importance of connecting those dots, sometimes across many years. Again, this deep dive into Bouveret syndrome focusing on this unique case drew heavily from the report by Fagiri, Abouali, Kindawi, and Imbarushimana in the Open Access Journal of Surgery. And our understanding was significantly shaped by the expert review from Dr. Reza Lankarani, general surgeon, founder of the Surgical Pioneering newsletter and podcast series, and editorial board member for the Genesis Journal of Surgery and Medicine.
And for those interested in digging even deeper, you can access additional details and explore more insights from Dr. Lankarani through the Surgical Pioneering podcast series application. The link is h-ttps://surgicalpioneer.codex.me. That's Surgical Pioneer, all one word, .codex.me.